what are we looking at when someone comes in and they go, I'm getting pimples?
Patients usually complain of pimples that they've never had before, redness that doesn't go away, flushing. Once you set up this inflammatory cycle, it just takes on a mind of its own.
They'll be surprised at how much things improve with just that really basic regime. But after that,
Well, I think
rosacea is a really common condition that so many people in Australia battle with. We're going to take a deep dive into the genetic causes, the triggers, and how you can manage it in your day-to-day life.
I'm Dr. Kate. I'm a dermatologist from Brisbane, Australia.
I'm Dr. Sam. I'm a consultant dermatologist at the Gold Coast, Australia.
Sam, I'm so excited to talk about this topic today. Rosacea. What is it?
It's the curse of the Celtics.
It really is.
It is. That's, this really common, but that's a misnomer. It doesn't just occur.
It does affect everyone, actually.
It can affect everyone. But we commonly, maybe just because skin is really fair
Well, the type 1 skin types really show it. So
Yes.
you can't get away with rosacea when you've got a fair skin type. So that's why the curse of the Celtics, I think, it has been named. But actually, it's quite a complicated disease process, isn't it?
It's super complicated. But before we get into that, how does someone know they have rosacea? Like, what are we looking at when someone comes in and they go, I'm 50 years old and I'm getting pimples? Well, that's the first clue. 50-year-olds very rarely just get acne. So they're getting rosacea. So what are they looking at when they look in the mirror?
My patients usually complain of exactly that, pimples, that they've never had pimples before, redness that doesn't go away, flushing excessively, that's so annoying when they're out, when they're having dinner, when they're drinking. They're probably the three key things I see complained the most when a patient.
And then once they start that flushing process, so it's periodic or sporadic, after a while it just becomes fixed. So someone might present with really ruddy cheeks or their nose is quite red and it's just there all the time and won't go away.
That's it. Like many things in the skin, I think once you set up this inflammatory cycle, it just takes on a mind of its own and then becomes a day-to-day phenomenon, which is really annoying with this disease.
So when I describe rosacea, I want to really empower patients to know what they are looking at when they look in the mirror. So that we've got flushing rosacea. It's called telangiectatic rosacea, and that's when you get maybe burst capillaries.
Yeah.
Papulopustular rosacea, and you get pimples that are a bit different to the acne kind of pimples you might have got when you were younger. And then you can get something called phymatous change, and that's where you get big chunky nose, chin, forehead, things like that. So there's this real gradient of rosacea, and anything in between can occur and they can overlap.
Exactly. There's been a real shift away from how we used to diagnose it into those quite discrete subtypes. But now we think of it more of a spectrum where one thing can actually lead to another and you can have all coexisting in the same skin and the same patient.
So why do we?
Yeah.
Why do we have them all?
I was going to ask you that question, but that is why this is such a complicated disease. I like to explain to my patients that the foundation of this disease is genetics. So you've really been lucky that you've got some good genes in your genetic pool that's setting you up for this condition. And then it's a bit about the perfect storm.
Yes.
So the skin immune system being a little bit faulty, a little bit of these Demodex mites that are commonly involved in the process. And it's not so much the mites being on the skin, it's on all of our skin. But in these patients particularly, you did look a bit infectious today. In these patients particularly, their skin, it causes so much havoc and it really drives this disease. And then the vessels, the blood vessels in rosacea patients are really sensitive. They react when they probably shouldn't. And that gives them that redness that is quite annoying and difficult to treat.
I think of one of the other things that I think is a really big problem is the barrier of the skin, which has contributed to like all of the things you just said. So you've got your Demodex mite, which is part of the normal bacterial microbiome of the skin. You've got the good, the bad bacteria, you've got the yeast, you've got the parasites. They're all sitting there in harmony. And for whatever reason, genetics, sun damage, inflammation, that Demodex mite starts kind of almost overflowing. It's down hair follicles, it's causing pimples and pustules. And then that impairs the barrier of your skin.
Yes.
So it starts this cyclical process. So sometimes people with rosacea notice their skin is like oily and pustular, but then it's dry and flaky in other areas. So it's this real juxtaposition.
It's quite a complex interplay, isn't it?
So complex.
That's really why it's patients with rosacea need a really good understanding of their skin and how to restore that skin barrier is foundational to making the treatments work as well. What's your preferred go-to as your first treatment option in rosacea?
First treatment option, I really like to reset people's skin. So it's almost like similar to our acne treatment. We've got to really dumb down that inflammation. They need gentle cleansers. I really like a milk cleansers.
Yeah,
and there's
so do
a
I.
lot of different brands. Avene and La Roche-Posay have some beautiful milk cleansers, good for sensitive skin. You don't want to irritate or inflame any further.
Definitely.
Then I'll add an active ingredient that is anti-inflammatory, so often a vitamin B3 or niacinamide, and then just a soothing moisturizer. And that might have something like hyaluronic acid and some ceramides, and again, a small dose of niacinamide. And I think just starting off really basic, stripping away every other thing that patients are using can really improve things just from a baseline. They'll be surprised at how much things improve with just that really basic regime. But after that,
well, I think another thing to add in is also the sunscreen, because these patients are so sensitive to UV.
Yes.
So even UV that's coming through window glass on the bus or in the car on the way to work, that's really driving their vasodilation and that red vessel change. So adding in a physical sunscreen, so a zinc oxide or titanium dioxide containing sunscreen can be really helpful in these patients. I then thinking about the dominant problem. So is it the pimples? Is it the redness?
Yes.
And then really honing in on that problem.
Yes, because there's plenty of people that have flushing, that telangiectatic rosacea with the blood vessels, and they're not getting the pimples. So there's no point in giving them something to actively treat this dysbiosis or giving them antibiotics to decrease their inflammatory load if all they're getting is blood vessels. So that correct diagnosis first, and then setting up our active. So let's just say they have that pimply pustular.
More of a papular-pustular subtype. So that's the patients that do really well with a Soolantra or Ivermectin topically, I find.
Okay.
So that's an ingredient which is focused on reducing the concentration of mites in the skin and taking out one of the inflammatory burdens.
Great.
So that can be implemented into their routines at night, and then potentially adding in an antibiotic on top of that orally. So taking a tablet as well for a short defined period of time to reduce the inflammatory load.
Do you ever use sulfur in your patients? I know it's a bit old.
It is an old school ingredient, but it works really well in rosacea patients. It works really well.
It's like a broad spectrum antimicrobial, but not specifically an antibiotic.
And so not too irritating.
It's not too irritating. It doesn't overdry the disease. Yeah, I feel like it just resets that microbiome a little bit.
Really well.
I usually get people to put it on at night because it can smell a little bit.
Okay, yeah.
But otherwise, it's a really great non-irritating ingredient.
A great ingredient. When do you reach for your lasers?
Oh, lasers, first of all, they're really fun to reach for, but don't do it too early.
Okay.
So if someone comes in with really inflammatory rosacea and you've got this U-But laser in the corner, you don't go straight to that. You want to settle that skin barrier. You want to decrease the inflammation, and then you look for a target.
Okay.
So there's a couple of different lasers you can use. Vascular lasers for the blood vessels, so those fixed telangiectasia, the burst capillaries, you might call them, on the face. So you can target them with a vascular laser. Or then if people just get that diffuse flushing, again, it's a type of vascular laser, but it's more like a micropulsed laser. So something called, you might be familiar with the term laser genesis, is really nice for decreasing that flushing. But it's not one, it's many over.
It is a sign up.
Yeah,
okay.
It's many over a period of time, because rosacea, unfortunately, is a chronic relapsing condition.
It is.
And it changes with the weather, with your mood, with what you're eating. So we want to be constantly managing that. And then the final laser that I might use, and this is reserved for people that have had rosacea for a very long time, is an ablative laser. Okay. And that's when people get those big bulbous noses or chin changes that are now permanent and fixed. There's no amount of antibiotics or topical medications that are going to get that.
Definitely.
So we use an ablative laser
to debulk
to debulk and physically vaporize.
And that works really well, doesn't it?
It works so nicely. The results are really, really good. Always got to pick your patients. There can be risks or downsides, but with an experienced practitioner, you can get very nice results.
So a completely treatable condition, we've just
manageable. I want to say manageable.
I
want to say cure. I want to treat it forever, but I also want to be realistic.
And there's some other treatments we can add into this. So Micro-Botox works really well for that really superficial dilatation as well.
Yes, it does.
And some low-dose isotretinoin, I think, works really well in this condition in chronic cases too.
The low dose is really interesting because sometimes people are a bit anti wanting to go on a long-term medication, but that really low dose can be 1 or 2 tablets weekly.
It's actually a lot lower than people understand.
It's so much lower. The side effects are nearly negligible at that dose. Not completely gone, but nearly negligible. It often is cheaper.
Yes, definitely.
Than investing and constantly having treatments. If you've got the vascular component under control and now all you've got is the pimples and pustules, it works really well. It works really, really well. All right, so we've talked just briefly about what the underlying cause is, But we know that different people respond to different triggers. So what are some triggers that you notice people have?
5 big ones that I generally educate my patients with. So the big one's UV light. So coming through window glass, out on a walk each day, you need to be sun protecting against that because that's a big dilator of those vessels. Alcohol is the second big one. Okay. So particularly vasoactive amines in red wine, that can be a big trigger for some people. Spicy foods and hot curries, they can flare the condition. Caffeine is a bit of a grey zone at the moment. There has been some evidence recently to say maybe that's not as triggering as we thought. And then just overheating and exercise can be a big debilitating trigger.
Right, so some people, I can see you getting I really like to go for a run, sometimes a little bit of hot yoga. I do enjoy champagne every now and again, as you all should. And sometimes I like some really spicy Vietnamese
3 shots in your coffee.
Food.
It's so a bit of a debilitating disease. What I like to say to my patients is these are the things that can set you off. Have a look in your day-to-day life and try and work out for you which ones are at play. A bit of a marker is how I'm going in treating your disease is how much of these you can take. Because obviously I can't take all those things out of your life.
Thank you.
So use it as a bit of a marker to see how our treatment plan is progressing. Fact or fad, rosacea. Number 1, Dr. Sam, does drinking alcohol and eating spicy foods, are they the root cause of developing your rosacea in the first place?
They're not the root cause. Fad.
Number 2, you can permanently cure rosacea if you find a perfect topical skincare routine.
Fad.
Number 3, Dr. Sam, that sun exposure is one of the absolute most common triggers for a rosacea flare-up.
I would say fact.
In Australia, definitely.
Yes.
Number 4, that using a physical face scrub will help buff the rough texture and bumps that are associated with rosacea. Ooh, I can see you visibly squirming with that one.
Don't do that.
And finally, fact or fad, Dr. Sam, do microscopic mites naturally living on your skin, are they a major contributor to your rosacea flare-up?
That's a fact.
If you want a full breakdown on any topics we've discussed in a bit more depth, just head to our YouTube channel.